Okay, I'll be starting. Доброго вечора, українські радіаційні онкологи, медичні фізики, радіаційні терапевтичні технологи. Слава Україні! Дуже дякуємо, що приєдналися до SBRT SRS course for Ukraine. My name is Natalia Kovalchuk and I'm a clinical professor at Stanford. I am a co-founder and president of Help Ukraine Group. I also belong to ASTRO and APM international committees. And we are running this course together with ASTRO International Committee and APM Global Education Training Subcommittee. Also, Raios Contra Cancer is collaborating with us and offering pro-no licenses for participants to do contouring and planning. So many thanks to all of our partners. So this course, like all our other courses, have AI-generated synchronous translation. You can turn on your translation by clicking on Show Captions, translation to Ukrainian, as you can see outlined in the bottom. So for this course, we have 161 participants that registered. 90 of them are radiation oncologists, 41 medical physicists, 19 RTTs, and other specialties and students. 40% of participants have up to 5 years of experience in radiotherapy, and 46% do not have any experience in SBRT. And as you can see here also, around 1/4 has minimal experience up to 1 year. That's why we are doing this course. And it's great to see that virtually all 40 RT centers register for this course. So there are 43 RT departments in Ukraine. Around 50% of RT departments do not use SBRT SRS, and most commonly used SBRT localization is bone mats, prostate SBRT, lung SBRT is performed only in 9 RT departments, pancreas SBRT in 6, and kidney, adrenal gland in 3 departments. The biggest barriers in SBRT SRS use in Ukraine is lack of 6D couch, as was reported by you, a lack of motion management systems, and also lack of knowledge. And that's what we are helping with. We are really trying to give that knowledge to you. So here's our course curriculum. We have 11 sessions, 1.5 hours each, every Tuesday at 10 a.m. PST or 8 p.m. in Ukraine. First 4 sessions are general sessions and the rest are site-specific. For site-specific lectures, you will have optional homework assignment. You will be using Prono, and we will send you instructions how to create an account, to use Prono to practice contouring and planning. We'll have a pre and post-course test to track progress, and during each lecture you will need to answer 5 multiple choice questions, and that's how we track your attendance. We will use these multiple choice questions then later on in your post-course test, so pay attention. Please make sure your Zoom name corresponds to your name, to the name that you would like to see on your certificate. We also applied for BAPER credits, and so at the end of the course, you will receive certificate of completion with BAPER credits. So let's start with today's lecture, and we have an amazing speaker. We are very honored to host Dr. Robert Timmerman. He is a professor and chair of the Department of Radiation Oncology, as well as professor of neurosurgery at UT Southwestern, and he is also holder of Effie Marie Kane Distinguished Chair of Cancer Therapy Research. Dr. Timmerman graduated from Iowa State University with Bachelor of Science degree in nuclear engineering, and from University of Tennessee with Master of Science degree in reactor physics. After finishing medical school in his home state of South Dakota, he completed residency radiation oncology at the Johns Hopkins Hospital. And early in his career, Dr. Timmerman specialized in treating brain tumors and other cranial abnormalities with gamma knife. He was intrigued by the idea of moving this sort of multidirectional precise treatment to other areas of the body, but there was a major hurdle at the time. Tumors inside the head don't move because of the skull is immobilized with frame during gamma knife treatment. But as a contrast, tumors in the body can move a great deal due to breathing and move waste of the intestines, but with more sophisticated image guidance and tracking, Dr. Timmerman and a few others began developing SABRE or SBRT, by which it was possible to account for motion and still deliver safely this type of treatment. Dr. Timmerman became known for his leadership in developing clinical trials to show how well SABRE worked in different parts of the body. One of Dr. Timmerman's greatest successes was development of RTOG-0236, a trial that demonstrated inoperable lung cancer patients treated with SABRE could have considerably higher tumor control than with conventional radiation, while still mostly avoiding toxicity. And this provided hope to a whole new class of patients, the elderly and those with multiple health conditions and others who previously faced poor odds of beating cancer. So his treatment method has now become the new standard of care for this class of patients. In his clinical practice, he continues to treat CNS diseases and pediatric patients as well. Dr. Timmerman currently directs training courses in SRS and SABRE, both at UT Southwestern and nationally for members of National Radiation Therapy Oncology Group. He's a highly sought-after guest speaker and has authored and co-authored numerous peer-reviewed articles and textbooks, and it's really an honor for us to host him today, and the Ukrainian community is really grateful for his contribution. So thank you so much for teaching us today on SABRE SRS, clinical indications and radiobiology. I will stop sharing. The podium is yours.
Okay. Well, thank you so much. And I'm going to try to share my screen as well. I sort of want to start out by saying I'm really sorry for the circumstances that you have to be engaged in right now with the difficulties in war. But I'm glad that, you're still taking care of patients, which is sort of the primary passion of physicians and medical personnel. So pray for you, and I'm glad to participate in this. This is where I live. This is my house on the hill in Texas. It's cliche, but I live in a ranch in Texas, and I have about 50 head of cattle, and we have a cow-calf operation. So it's fun to be home. Oh, shoot, no, it's not sharing. Let's see. Is it sharing? Do you see it?
Yeah, we can see it.
Okay.
Perfect.
So I was asked to sort of give introductory remarks and then talk about rationale in radiobiology. And this is quite different. I think that I like to call it SABRE. I don't like the name SBRT, but so that's how it'll be referred, but those are the same thing. And in this context, SRS is stereotactic radiosurgery, which is a single fraction treatment that's primarily done in the brain, but it's also done in the spine. And there's a long history of it being done in the brain. And again, SABRE, the body counterpart of brain radiosurgery, is an offshoot of brain radiosurgery. And so early on, most of the people that were doing SABRE in the body were CNS doctors because they were more comfortable with the techniques. I have no disclosures. And then I also wanted you to understand just how profoundly different this is than conventional radiotherapy. And if you approach it with kind of a conventional radiotherapy perspective, I don't think it will reach its full potential, and it will not help patients as much as it could. But mind you, this is around 1995 when we were first thinking about doing these treatments in the body, and treatments in the brain had already been done since the 1970s. And at the time, the biology of radiotherapy was basically the study of DNA damage and repair. And in that context, then we worked on the treatments like this, and our goal was to damage as much tumor DNA as possible and avoid damaging normal tissue DNA as much as possible. But it was really and I think what we did will be consistent with that perspective, that that's what matters. That's the biology. The biology is DNA damage and repair. Now, what you're going to find as I move on is that that was a wrong assumption. There's more to radiotherapy than just DNA damage and repair. But keep in mind that at least how this treatment has evolved, that was where it came from. So again, we're trying to give highest dose as possible to a tumor. And so our early studies were dose escalation studies that tried to increase that dose to where we would finally kill a tumor. And at the time also understand that with fractionated radiation against gross tumor, control rates were in the 30 to 50% range at that time. And you'll see that we did much better with SABR and SRS than 30 to 50%. And also understand that it's so different in that typically with fractionated radiation, you respect what are called the 4 R's of radiobiology. That is, again, the first R is repair, and that DNA damage and repair is more, normal tissues are more likely to repair damage than tumor tissues, and you try to exploit that. The next R is accelerated repopulation. That is that tumors or normal tissues in response to radiation might actually proliferate. Third is redistribution, which is that cells move through the cell cycle and they're more sensitive near the mitosis than they are in other phases of the cell cycle. And then the fourth R is reoxygenation or the oxygen effect. That is, hypoxic tumors are more resistant than normal tumors. Now, this is going to hurt your feelings or your sensibilities, but I'm going to tell you that 3 of those 4 R's of radiobiology don't apply to SRS or SABR. In other words, repair is really unlikely in the target. So there's not a differential repair. There's just a bomb that went off in the tumor after you give these types of treatments. And so there's no differential repair. There's no repopulation. That is, there is not an accelerated repopulation when you give doses. It's sort of the minimum is 6 to 8 gray, but if you're over 6 to 8 gray in a dose, there will not be an observation of accelerated repopulation. And cell cycle effects, that is the redistribution, is sort of a moot point when you're only giving a few treatments. That's something that matters if you're giving weeks and weeks of treatment because the cell cycle is so slow. So the only one that applies is oxygen. The only R that applies to this is oxygen. And I think that's a good introduction to it because all those other things matter so much to conventional radiotherapy, and they hardly matter at all to this type of radiotherapy. And because of those four R's, we often would try to make a dose very homogeneous in a conventional radiotherapy portal, partly because most conventional radiotherapy portals are mostly normal tissue. That is, when you treat a head and neck cancer, 95% of what you treat is normal tissue with no tumor in it at all. And so you purposely, would try to not overdose areas of that normal tissue with a heterogeneous dose. But as we'll talk about, that's not really an issue with SABR or SRS, where we don't care if there's a big dose spike inside a target. And in fact, things like the flattening filter on your LINAC were important for homogenizing dose. They're totally not important for SABR or SRS. And then the other thing is that SABR and SRS are ablative. And so we were able to double local control, and I'll show you the data in a second, because we gave ablative treatment. That again is a type of treatment that's very different from 2 gray. And I'll show you what I mean by that when I say the word ablation. And ablation is facilitated by hypofractionation. And I'm sorry to show these curves, but this is so important. That is, everything that is treated with radiotherapy or chemotherapy follows a deterministic, non-stochastic a deterministic sigmoid dose response curve. And the way that works is that when you first go out in the sun is radiation. So if you go out in the sun for 15 minutes, if we all do, hardly any of us will get a sunburn. So let's say the treatment effect is a sunburn. We're out for 15 minutes and none of us get a sunburn. And that goes on for a period that you'll increase the exposure. And in that region called the threshold, there's minimal dose response and really minimal treatment effect. But then it changes. Some of us at 1 hour will get a sunburn. Many of us won't, but some of us will. And so increasing exposure to the sun will give more of us sunburns in this transition portion. And so in that portion, there's a striking dose response effect. Again, a deterministic, it's a probability. And the treatment effect will be variable, but increasingly profound. And then finally, you'll hit a plateau where if we're out for 18 hours in the sun, all of us will have sunburns. And so we've got the maximal treatment effect. There's no dose response after the plateau. It's maximized. And this is a very important biological observation of radiation. And SBRT and SRS exploit this, as I'll show you in a second. And it turns out there's a different curve offset a different amount for every effect that we want to measure. So like if you're going to give 2 gray per day for a conventional fractionated treatment, that 2 gray has to do something in terms of DNA damage, right? So in terms of the curve, the one I've shown here, effect number 1 might be DNA damage. It's got to be on the transition by the time you give the dose. If you give the dose below the transition, you won't get any effect. You'll be on the threshold. And so 2 gray causes DNA damage. Not a lot, but it causes some. But what I'm saying is that there are other effects that we're going to talk about in a second that may not happen. Their threshold may be much broader. They may not be observed at all until you get out to much different doses. And some of those effects have been described, like blood flow changes effect in their density. And Hallahan's lab showed that that's not first observed until you get 16 gray. So if you give 2 gray, you don't see this at all. The same is true of the ceramide pathway in the Fuchs lab. And immune effects often are not observed at all either until you give a pretty big dose of radiation. And so like Wechselbaum's lab showed that immune stimulation didn't occur until you first gave 15 gray in a single treatment. If you gave 2 gray for the same dose, you wouldn't necessarily see these effects. And so that's something we can exploit. That is, there will be effects that will occur at one dose but not at another. And some are good, some are bad, but that can be exploited. And again, this is a very different treatment from conventional radiotherapy. It's typically a gross tumor only treatment. That is, we're not treating for microscopic disease, with rare exception. We are typically not treating a whole organ, so there's again a few exceptions like prostate, but in general, you're going to outline the tumor and you're going to treat the tumor with the smallest margin as possible. And then the physicists help us construct very rapid fall-off dose from where you're going to try to wreck things to where you're going to try to preserve the function of things. And so that these are steep gradients in all directions. The treatment needs to be both accurate and precise. And I've got the dartboards showing you what that means. That means you have to hit the bullseye every time, and every shot has to hit the bullseye, not just a few of them. And then you really want to avoid large margins. Margins can quickly become bigger than the target if you're dealing with sloppiness, and that includes motion. And so that is a problem, like was mentioned, that occurs in the body that's not such a big problem in the brain. Brain has other problems. Brain is not easy, but at least it doesn't have motion. So SABR and SRS are technologically intense, But I think it's important for you to realize they're not biologically elegant. Fractionated radiation is biologically elegant. That is, this trying to exploit the difference in repair, which is a cellular function between tumors and normal tissues. That doesn't exist with SABR or SRS. These are simply hit this and not that. And so you're hammering the tumor and you're avoiding normal tissue by simply not hitting normal tissue. We call this geometric avoidance. And typically technology is used for geometric avoidance, but can be other ways too. The first stereotactic radiosurgery was performed by Lars Leksell, a neurosurgeon from Sweden. He had invented a stereotactic system where he would guide surgical instruments and sort of using the concept that the least trauma would be a straight path through a small conduit. And then he thought, well, if I can guide a biopsy needle through the brain, why can't I guide a beam of radiation through the beam? And in fact, the first radiosurgery that he did was with single beam. But by and by, he thought if I can guide one, I can guide 2 or 3 or 100. And the treatment evolved to this concept of multiple weak beams, each causing relatively little entry or exit damage, but converging on a target to sort of accumulate a very high dose. And this facilitated the hypofractionation. He was a surgeon, so he didn't know anything about radiation oncology. And radiation oncologists were giving fractionated radiation in the 70s, but he was a surgeon, so he did it in one treatment, probably to the chagrin of radiation oncologists. And then SABR, sort of again the offshoot of that treatment, was enabled by these things: comfortable, reproducible, stable immobilization. We still use these frames to treat our patients, and they were really essential early on because they had a stereotactic system of coordinates inside them. And that's not necessary anymore with image guidance, but we still use them because they're so comfortable. They're so much more comfortable than lying on a flat table or lying on a vac bag that's otherwise not hugging you. We require good dosimetry. I'm sort of showing you how fast things fall off in a lung cancer case here. From, the hot spot is 67 gray in 3 treatments. The prescription dose is 54 gray, but not too far away, we're already at 27 gray. And you can polarize that fall off dose if you think there's a better way to spill it. And if you don't know the better way, it should probably fall off isotropically. We realign the treatment with image guidance, primarily cone beam CT. And then we deal with motion first by understanding the motion. That's called motion assessment. And then if it's not good, if it's too much motion, then we do something about it, which is called motion control. And the typical ways we do motion control is with abdominal compression, which encourages something called chest wall breathing. The 90% of the studies that we did, the centers that enrolled the patients used chest wall breathing from abdominal compression. Gating is an option. That's what we do with our MR-Linac. Tracking is more sophisticated, but it's being done now as well with different platforms. But all of those would allow you to treat a smaller volume, even if the target is moving. Notice I didn't mention 60 couch. The 60 couch is useful, but like the patient that you're looking at in the middle frame there, in fact, the upper end middle, that's a simulation. The middle frame, that's not a 60 couch. We haven't, 60 couches are handy because they can correct both translations and rotations, but most of our treatments are not done on a 60-degree couch. And I think what's more important than a 60-degree couch is reproducible, comfortable setup, because then you won't have many of those types of things that you need to correct, like rotations. And so a frame, again, is a really useful way. And many of our frames are homemade. We make them in a wood shop. So here's the first question. The question is, characteristics of SABR SRS include which one? There's only one correct answer of the following. And there's A, B, C, D. do I read the answers too, or do I just let them read it? Or so A was first developed and clinically tested by a radiation oncologist. Uses wedges. B uses wedges and tissue compensators to homogenize dose. C produces deterministic non-stochastic effects in patients. And D is accurate with dose delivery, but not always precise. And then you said when we get like 80%, we'll stop.
80%, yes. So
Okay.
we need a little bit more votes.
Not many more.
Yeah. So they're doing great. So yeah, we're ready to stop. Okay, thank you so much for responding. I'm ending the poll, sharing results. So most answered C,
Yeah.
produces a deterministic non-stochastic effect in patients.
Yeah, and that's correct. And again, I made a fuss about that particular point. That is, everything in radiation is sort of like if you turn the dose volume control knob, you're going to see these sigmoid dose response curves. So the sigmoid dose response curve is characteristic of a deterministic effect. And we exploit that to a great degree, and so that's why it's important. The first development of SRS was neurosurgeons, not radiation oncologists. And in fact, if radiation oncologists would have done it, I don't think we would have given big doses.
That's true. It was
And
too scary, right?
and in SRS Sabre, we really don't care about homogenizing dose. We have very heterogeneous dose distribution. So I remember I told the engineer at my first center when we were doing these treatments, I said, "Can you take the flattening filter out of the machine?" And and his response was, "Do you know how hard it was to get it in there?"
That's
Um,
crazy.
and then the final needs to be both accurate and precise. We just
Hmm.
can't miss. We have to be accurate. So I'm going to close the poll,
Hmm.
move on. And so, like I said, I think probably the most profound thing we did in the 90s was we didn't use the Sabre enabling technologies that I just mentioned to give 2 gray. We could have. In fact, that's exactly what proton people did. I mean, when protons came out, they could have used it to give 20 gray, and instead they just used it to give more 2 gray per fraction treatments. And protons was a very enabling technology. And I personally think that that was the big mistake. They could have made protons far more important in terms of its impact on patient outcomes if they wouldn't have done that. So I'm proud of that we didn't give 2 gray per treatment. Let me see, I can't get this to move. Okay. And then and again, as I said at the beginning, we only thought about DNA damage and repair. So we thought that we need to find the highest dose that you could give with this approach and treat everybody with that highest dose that we could give, because that's how we would get better cure rates. Noticeably absent though was we didn't think at all about immune effects when we started sort of the journey of SBRT and SRS, or metabolism. And the other thing is we didn't think at all about personalizing therapy. We treated everybody like they were the same as long as they had the same diagnosis. And I think that's was a really major mistake in the early days of the treatment. And so when we first started treating these patients, it was very common to treat metastasis, like liver metastasis or lung metastasis, and then reported the results. And people were very skeptical. People thought, "What you're giving, 15 gray times 3, that sounds crazy." And then we said, well, they seem to be tolerating it very well. And then the answer to that was, well, that's because you're treating people who are going to pass away within 6 months. And so then we had to come up with a clinical model where they would outlive the toxicity. That is, they wouldn't die before they had side effects. And so there really were two choices at the time. One was early stage lung cancer, and that's the one I primarily focused on. And the other was hepatoma patients with cirrhosis. But let me tell you about the lung cancer story. So first what we did was we went to a phase 1 study, started out with a dose. It's ablative. 8 gray times 3 is ablative. Some people say it's not, but they're wrong. If you treat lung to 8 gray times 3, the lung will be totally dysfunctional. If you treat the esophagus times 8 gray times 3, you'll have major esophageal problems. So 8 gray times 3 was the starting dose. Nobody thinks that's a super high dose now, but that's a pretty special dose. And we escalated all the way up to 24 gray times 3. So these are probably some of the highest doses that have ever been given in the field of radiation oncology. And what we did was we just looked before and after treatment, what was their pulmonary function. And surprisingly, we saw hardly any toxicity, even though the dose ranges became enormous with this new approach. And again, that's why, again, it's very different than people would have predicted with their mindset. And then we looked at local control as a function of dose as well as survival. And we're back to that sigmoid dose response curve. So what we saw was that at a dose of around 30 gray and 3 treatments, you had about a 40% control rate. That's what conventional radiotherapy can get at about 60 gray and 30 fractions. But as you increase the dose, the control rates went up. And in fact, we started to hit the plateau of the dose response curve for local control. And this is pretty exciting. That had never been done before. There had never been a treatment that was plateauing at nearly 100% local control for the treatment of an evil disease like lung cancer. More impressively, was that the toxicity curve looked like this. We didn't start to see toxicity until we got around 70 gray in 3 treatments. And what that means is we had an enormously wide therapeutic window with the treatment. That is, people getting the goal of the treatment was to kill the tumor. We killed it, and very few people had side effects. And we could back off on the dose because we had passed the plateau where there's no dose response. If you keep going on the plateau, all you'll do is buy toxicity for no benefit. So we lowered the dose to 54 gray, and that was tested then in this study, which was mentioned earlier. And by the way, this is 15 years later. So 15 years between that and this study, and this was published, and this was the turning point of SBRT or SABR in the body, because it was in a population that would live long enough to show toxicity, and they did not show toxicity. And the treatment had a very profound effect. It had 95% local control. And again, the same population treated, 15 years earlier had 30 to 40% local control. So the local control, by the way, is not victory. Local control is first base. In other words, you have other problems that can still affect these patients down the road to where they won't survive, but at least you don't have the tumor that you saw in the first place. And then the question is, what problem did we avoid? We avoided late effects. Late effects were something that were observed in a very negative way 100 years earlier. And the late effects are basically tissues that lose their vitality, tissues that can't support themselves, tissues that fall apart. They're wounds that will not heal. And that they had been common. It gave a really bad reputation to hypofractionation, and to the point where most people in the field wouldn't do it. But with these new techniques, with this technology, we were able to do it without a late effect. So that publication proved that you could treat early stage lung cancer and avoid a late effect. Now, the tumor was dead 95% of the time. It was at a very high dose. It was totally ablated. There was a zone right around the tumor that must have been damaged badly, and yet it didn't necrose. We didn't see lots of side effects in that. So what we're seeing here is a phenomena that is not something that has been observed with conventional radiotherapy, that it was historically given to very large wide fields, which is tissue healing, tissue tolerating therapy, uh, right next to tissue that was totally destroyed. So fractionation is about avoiding injury. SABR must be about healing injury. In the US at this point, 30 to 40% of patients treated in the United States get SABR or SRS. The primary tumors of many different types, and this is after hundreds of clinical trials, really opened up a huge new indication for radiotherapy, that is treating metastatic tumors, not for palliation, but to try to improve the survival of a patient. There's holdouts, but I think they'll eventually succumb too. And keep in mind, this is in a country where you get paid per treatment. So, by giving 5 treatments, you get paid a very small compared to if you gave 30 treatments. We would get paid enormously more if we give 30 treatments than if we give 5 treatments. But nonetheless, 30 to 40% penetration, and that number will just keep going up, especially if the billing model changes. Now, to switch gears a bit, I do think it's important for us to understand architectural issues, that is, the way that tissue is composed, tissues and organs. And for years, we've used this parallel and serial structure, and it's very useful. I mean, I think it's simple, but it's very useful. Parallel tissue is monotonous organ parenchyma. And so the lung is considered a parallel organ. And so the top of the lung is doing this. Let's see if my mouse works. How do you make the mouse work?
Yeah, I can see your mouse.
Oh, good.
Yeah.
The top of the lung does the same thing as the bottom of the lung. There's, and so this is monotonous parenchyma and function. We've done very well with SABR in parallel tissues, organs that are called parallel organs. And what you got to do for them is just make sure you don't destroy more than the amount that's critical. The critical volume is defined as how much of your 2 lungs do you need just to do respiration. And it turns out you only need about 1/3 of your total lung function. That third rule is true of every organ. It's true of your spit glands. It's true of your liver. It's true of your kidneys. So all these kind of glandular organs need at least 1/3. And the other 2/3 is reserve. You don't actually need it. It's extra in case something bad happens to a section of your. And so as long as you stay to where they have more than 1/3, and so you can remove a lung and you can still breathe. You can remove a kidney and you can still have kidney function. That's a half. And so that's been okay. And then the serial structures are like tubes and wires. So the esophagus, and the function of the esophagus is to be a conduit for food to get from your mouth to your stomach. And so it acts like a tube or a wire, and this has been very difficult to do SABR around these tubes and wires. Now, I just called the lung a parallel organ, and the reality is, and this might be in a question, the reality is that the lung is much more than just a monotonous organ parenchyma. It's got branching tubular structure that goes from your trachea to your bronchus to the more minor airways, and they're all serial. And they have profound effect on the tolerance of a treatment in these organs. But it's very true that serial structures give us the most nightmares. That is, you're going to have more toxicity from injuring a serial structure than a parallel structure. And then the other thing I want to tell you is that parallel structures are damaged at a really low dose. And the reason is they can afford it. They don't repair that much. So like, in conventional radiotherapy, 20 gray will destroy the lung. So the lung that gets 20 gray in a conventional radiation treatment is destroyed. And the patient still breathes okay because that's not enough for them to become symptomatic. You'd have to, again, damage more than that. Serial structures repair really well. I mean, they have to, because if they don't, if you cut a wire and it can't repair, then whatever that was, the function of that wire was, will never happen again. So serial structures have much higher tolerance to radiation than parallel structures, and they repair exceptionally better, some better than others. So the thicker the wall on this tube, the more likely it will repair. So like capillaries don't repair as well as named arteries. And these are all things you have to think about when you're doing SRS or SABR in the body. Now let's get to this term ablative. The surgical definition of ablative is the treatment that destroys or burns. And so a cautery iron is an ablative tool. It destroys things by burning it. But in radiotherapy, we have a very different definition. And the definition arose from treatments that were still some of the best treatments that we do, the radioiodine treatment of thyroid cancer. And what you would do is you would remove the tumor in the thyroid, and then you'd give them radioactive iodine to ablate the residual thyroid gland. And that way, if after the treatment, you could use thyroglobulin as a tumor marker. And because if you didn't ablate the thyroid gland, the thyroid could make thyroglobulin. You wouldn't know where it came from. And so what that means is a treatment that will destroy the function of tissue. And in this case, thyroid tissue's function is to make thyroid hormone, and it can make thyroglobulin as well. So like anything like a gland that makes a hormone, that would be its function. The lungs function is respiration. The esophagus function is be a conduit. And so if you ablate that function, I mean, if you destroy that function, then you've ablated that tissue. And so like treatments for prostate cancer with SABR are really good at dropping PSA. PSA is a function. That is, different tissues can make PSA, and the radiation treatment is really good at dropping that. And the dose potency needed to disrupt function, since it's usually coded by one gene, is much higher than the dose needed to stop mitosis. Because in the first cell, you could stop the spindle formation. In the next cell, you could stop some other aspect of mitosis, and any one of which will stop mitosis and stop cell proliferation. So the dose required for ablation is much higher potency-wise than the dose to stop clonogenicity. And then the question is, do we need to ablate? And the answer is no, we don't need to ablate in general, unless you're treating like a pituitary adenoma that's secreting growth hormone. But the likelihood of completely stopping the ability of tissue to proliferate is more likely if you use ablative dose radiation than if you use lower dose. And then we also have this threshold effects that I talked about earlier, where we could take advantage of vascular effects so it's not just about just damaging the tumor's DNA. It could be about damaging the tumor's blood supply, or it could be enlisting the immune system to help you kill the tumor, not just relying solely on the radiation. But very importantly, and I don't mean to be cavalier, there's absolutely no benefit to ablating normal tissue. And that got sort of a sobering reminder to us when we give these treatments. So we want to abandon prophylactic treatments, that is, just treat the tumor. We try to reduce the intermediate dose to the normal tissues, because it's not magic. You do have to give a high dose to a target. You have to have a fall off gradient, and that's going to be in the normal tissue. You use many beams, more the better. Non-coplanar is better than axial beams. 4 pi is better than like what you'd get from these new machines that only are axial. Use small margins with prudence. That is, any fool can use a small margin, but you got to have a small margin and hit the target. And lots of techniques to get that. Now, I was trained to treat lung cancer this way. This is back in the early 1990s. So the beam came from the front, beam came from the back. And then after a cord tolerant dose, we went off cord, and it created this dose distribution. And this dose distribution, and this was in a 2D and a 3D era, The high dose looked like this, that that we call it a parallelogram, right? So that's what the high dose looked like. The intermediate dose looked like this. It was basically anywhere where these few beams traversed. And the low dose, and by high dose, I mean 60 gray. By intermediate dose, I mean 20 to 30 gray. And by low dose, I mean like 5 to 10 gray looked like this. And a couple things from the bat, we can talk about this. This particular dose distribution, the high dose is not conformal. The tumor is not a parallelogram. And so this didn't need to be treated. Only this needed to be treated. And yet we gave high dose to that region up there. And then the other thing is the intermediate and low dose were the same for this beam arrangement. And this beam arrangement was used for decades. I'm sure others in the call have used this to treat lung cancer. And this is where we got confused about low dose. So some people have worried about V5. You've heard of people scrutinizing V5 as part of a treatment plan. That is total nonsense. Stop doing it if you're doing that. And this explains why people got confused, because this low dose and this intermediate dose are the same thing. Intermediate dose does matter. So if the intermediate dose relates to toxicity and the low dose is in the same geometric distribution, then obviously the low dose will also correlate to toxicity. But when we did this treatment, which was a couple decades later, and this was done in RTOG 0617, it gave this distribution where the high dose looked like that, the intermediate dose looks like that, and the low dose looks like that. Notice, first of all, that the low dose is enormous. The low dose is enormous. So the high dose now is conformal. It is in the shape of the target. The intermediate dose is much smaller than it was in the last one because we've spread out the entrance dose. And the low dose is extremely large. And this is the trade-off that you have to make. And if you can't make this trade-off, you can't do SBRT or SRS. That is, you exchange monstrously larger low dose bath for a smaller high dose and intermediate dose treatment. And this makes sense, again, according to the sigmoid dose response curve, because if these are our 3 dose levels, and again, the threshold, the transition, and the plateau, for the high dose, we want to keep it very small because it's very toxic. I mean, whatever gets hit by the highest dose, whether it be 70 gray in 35 treatments or 54 gray in 3, it's going to be badly damaged. And we want to keep it as small as possible. The intermediate dose, where most of the toxicity comes from, is also toxic. And so we would like to keep that as small as possible. And then we do that in exchange for a really large low dose. Because what low dose doesn't cause toxicity. If it did, we would be in big trouble. We concede it. We concede that. And this is not a crazy idea. This is a brain treatment, a gamma knife treatment. And the way the gamma knife works is that it brings like 200 beams of radiation. It didn't work very good, but and they all go through all parts of the brain, left, right, forward, back. They converge on the target, and all of this entry and exit dose that's out here ends up a low dose bath. And we've been doing this now for 50 years or more in the treatment of the brain. The brain is the least tolerant structure in the human body, and yet for 50 years of positive experience where this is a safe and effective treatment that can help patients without toxicity. And so make your SBRT treatments look the same as the cyber knife or the gamma knife or whatever you use in the brain treatments. Use conformal arcs, multiple beams, more the better. And sadly, a lot of the new platforms now are getting farther and farther away from 4-pi. 4-pi means the beams come in from anywhere, but that would be more ideal for this. So here's question 2. Ideal treatment planning for SABR includes all the following except which one? You should lateralize the beams to the involved side of the tumor target. B is use non-coplanar beams as much as possible. C is account for motion to avoid larger PTVs. And D is keep the patient comfortable in the treatment position. So which one is wrong among these?
So we have around 75%
Okay.
answering. Okay,
Yeah.
almost 80. Yes, we got it.
Very good.
Ending the poll, sharing results. So majority answered A, lateralize the beams to involved side of the tumor target.
Yeah, so this was, I'm terrible at writing questions, but you were supposed to say which one was not correct
Not
for
correct.
ideal planning. And you and again, it goes against your conventional training, but if you have a tumor on the right, bring in plenty of beams from the left. And the beam should come from above, above the tumor, below the tumor. You spread out that entrance dose. The more beams, the better. And so then the common practice of lateralizing beams to the involved side of the target is not a good idea for SABR. We would generally let them come from all directions. Because again, we believe that low entrance dose from a multiple beam treatment will be on the threshold of the dose response curve and will not hurt the patient. And the Gamma knife, for example, brings in beams that go straight through the eyes. And people always say, that'll cause a cataract. No, it doesn't. Not if there's enough beams. It does not cause a cataract. So anyway, and then the others are just a good idea. Non-coplanar beams are a good idea. You've got to account for the motion to shrink the PTVs. And then I just can't say enough about being comfortable for a treatment that takes a little longer than a 2-grade treatment. And so the more comfortable they are, the better you'll get. All right, I'm going to close the poll. Now, these are the planning priorities that we originally outlined for SBRT. Number one was respect the spinal cord constraint. And that is because if you damage the spinal cord, it's just too hard for a patient both to tolerate, and most patients can't understand the magnitude of it. In other words, if a patient said, go ahead and wreck my spinal cord as long as you kill the tumor, I don't think they understand what they're saying. So we respect the spinal cord constraint. The next thing is you cover the tumor conformally. And I mean cover the tumor conformally. That is, if you skimp on part of the PTV and give it less than a meaningful dose, then the patient will recur there and with higher probability. And that'll be the hardest situation to salvage. You create very good fall-off gradients, compactness of dose, we call it. That is a good treatment plan. We've just discussed how you might consider doing that. I didn't tell you exactly how to do it, but other physicists will tell you that. And then finally, respect normal tissue constraints. And I know that probably is going to hurt your feelings. That number 4 is respect normal tissue constraints. But I'm going to try to make the case as to why. And again, this is a different tool than conventional radiotherapy, where we would have put this one way up the list, right? So normal tissue constraints are meant to avoid normal tissue injury. And they also are quite useful in terms of the general principles of ALARA, of keeping things as reasonably low as possible, as well as they're really good for making protocols consistent from site to site. That's one way you can really make the treatment similar at Stanford as it is at UT Southwestern, as it is in Ukraine. But the question is, should they be hard stops for a reasonable treatment? And I think that's different somewhat from, will you be accused of being a bad doctor by somebody if you exceeded a normal tissue constraint? I hope not, but that's possible too. So there's really clinical scenarios that make this come into reference. Let's pretend we have the esophagus and a tumor that's kind of far away from the esophagus, a tumor that's touching the esophagus, or a tumor that's in the wall of the esophagus. And this is going to make it relatively harder or easier to meet constraints, right? And so in the first one, should you respect the constraint of the esophagus to treat this tumor over here? And I would argue absolutely yes, you should. That's don't take a risk when you don't have to. This one, some of you might, some of you might not. I would, but many of you probably aren't so ready to do that. And this one, I would sort of avoid SABR if I were you, because that's going to be really difficult. So let's think about this carefully. If you decided to be more like me and treat tumors near an important serial structure, I use the CUT strategy, calculated useful trauma strategy. That is, this would be the PTV. This portion of the esophagus overlaps it. If I give the full dose to the PTV, or at least a potent dose to the PTV, I am going to injure the esophagus, no doubt about it, 100%. And in doing so, I will likely exceed anybody's constraint for the esophagus if I did that. Now, pretend I did it anyway, and then what we'll end up with is an injury to the muscular wall of the esophagus and a mucosal injury that will manifest as an ulceration. Now, will that ulceration heal? It's injured, no doubt about it, but will it heal? And the way it would if it did is stem cells that are not in the immediate vicinity, but still within the circumference of this esophagus, will migrate just like they do when you scrape your elbow on the concrete. If you scrape your elbow on the concrete, the skin on the edges moves in to cover up the weeping part that you scraped. And over the next several weeks, it'll heal up if it's not too deep. If it's super deep, then it may not heal up. If it's super big, it may not heal. And what would we do in that case? We would do a skin graft, which is a stem cell transplant, and put a patch of skin here. But if this was small enough, it would heal. And again, I told you previously, serial structures are really, really, really good at healing. And the way I prove that to you is the field of surgery totally depends on that reality. That is that, sorry, that tissue, that serial structures can heal, because the skin is a serial structure, and bowels and all that. So you would do a treatment plan where you didn't try so hard to protect this part, it's going to be damaged. What you would try with IMRT and other strategies is to really aggressively spare the contralateral side of that lumen, where the stem cells will come from to rescue from the injury that you caused on the involved side. And in reality, even you might say, well, that sounds crazy to me, I'll never do that. I've had other doctors tell me that. But those same doctors, whether they admit it or not, exceed the tolerance of constraints all the time. If you treat a glioblastoma to 60 gray, you have exceeded the tolerance of the brain. And if that patient lived long enough, they would end up with little micro holes in their brain called cavernomas that would prove that. When you give 60 gray to the esophagus, you have just exceeded the tolerance of the esophagus. If you give bladder treatments, if you give a brachytherapy treatment to the prostate, you have just exceeded the tolerance of the posterior rectal wall. So it's if we were honest, we all exceed tolerance. And the question is, do you do it mindfully? Do you do it with a strategy to repair the injury that you will possibly cause? And I think, like in this prostate trial that we did, and this was the first time we ever did this, so we didn't know what the tolerances were. But two different centers. The one on the left I treated, the one on the right was treated at University of Minnesota. And we had a balloon in the rectum, and we were giving the prostate pretty high dose. Again, in those days, I thought the goal was to go to as high a dose as possible. And now I don't know that we needed that high a dose, but we were at 50 gray treating the prostate. And what we found was that there was an anterior rectal wall injury. I didn't show a picture of it, but the patient on the left had an anterior rectal wall injury that ultimately required a colostomy. And the patients on the right didn't have any toxicity at all, or at least they didn't know it. In other words, they reported no toxicity. And look at the difference on how much circumference was spared between these two treatments. And it turns out through this analysis of figuring out the dose distributions of those that got hurt versus those that didn't, the real important dose is 39 gray. 39 gray in 5 treatments will totally depopulate all the stem cells in a mucosa. And it has to do with how far how far they would have to travel to rescue the side that you injured. And so if it was less than a third of the rectal mucosa that got depleted with 39 gray, then the patient did or didn't have toxicity. And it was so striking. And what's important about this is you cannot get this information from a dose volume histogram. The only way you're going to get this information is to look at the plan and think about the injury and think about how it's going to heal. And if you do that, you're going to be so much more successful with SBRT. And then the rectal spacer came along. This big white thing here is a rectal spacer in the prostate in front of it and the rectum behind it. And now this high dose misses the rectum entirely. So that sort of solved the problem. But here's question 3. Concerning tissue architecture and the use of SABR or SRS, which one of the following statements is correct? A, if normal tissue constraints are not observed, toxicity will occur. B, serial tissues are relatively easier to tolerate SABR than parallel tissues. C, PTV coverage frequently conflicts with respecting ORA dose constructs, organs at risk, dose constraints. Or D, lung and liver are predominantly parallel structures.
Okay, we are almost there.
Yeah, it looked
Yeah.
like this question kind of threw people for a loop.
Split, yes. It's challenging.
Yeah. Well,
Yeah.
I think that you may not agree with my answers, but
Okay, so it's a split between these options, but most people answered C, and I think that's a correct one. That's what you're gonna say.
yeah,
It's correct, yeah?
yeah. I mean, so the PTV often overlaps with an OAR, and
Yeah.
so you can't be on both sides of a river, and
Mm-hmm.
so you're going to have to either underdose the target or potentially exceed a dose constraint. So C is the correct answer. And the first one, if normal tissue constraints are not observed, toxicity will occur. I exceed normal tissue constraints every
All
time
the
I
time.
treat. Oh, what's that? Yeah, I
All the
exceed them
time.
every time I treat a patient. And so I do not observe toxicity every time I treat a patient. So I think that one is not true. And it again is a testament to the amazing healing capacity of the human body. Uh, Serial structures are not the easiest to tolerate SABR, they're the worst to tolerate SABR because SABR often exceeds even though serial structures have more radio resistance or more radio tolerance than parallel structures, SABR often exceeds that. And so
Mm-hmm.
that's a difficult problem. And the last one, I don't blame you for thinking that that might be the
Yeah.
right answer. Everyone says that. But let me
Yes.
tell you that lung and liver have tons of serial structures inside of them.
Mm-hmm.
And we're increasingly learning, and I didn't talk about it enough to justify the question, but the airways that branch into the liver and the lung, into the lung and the bile ducts and vessels that branch into the liver are probably more important than the parenchyma in terms of toxicity. And so that's probably to come, and we'll probably be using that information to generate better treatments in the future. But there we go.
I find that we are very simplistic in thinking about toxicity and correlating to dose. Don't you think it needs to be more like patient specific as well?
I do.
But
And
it's very challenging to
yeah,
realize
and
that.
like it's really hard to see bile ducts. So
Right,
at least it's not a good imaging to see bile ducts. There is imaging to see airways though.
right, right.
And so airways might be the first thing to tackle, to do a
Mm-hmm.
personalized treatment plan that spares key airways.
Mm-hmm.
Remember, airways have a downstream effect. Even parts of the lung that you're not going to irradiate at all are still affected by an airway that might be in the vicinity of where you're treating.
Right. Yeah, that's right.
I just wanted to show you really dramatic improvements in prostate cancer treatments. I learned to treat in 2D again in the 1990s. And this was the 4-field box for a prostate cancer treatment. And then things moved to 3D. It got more conformal. IMRT started to spare the posterior rectal wall. And then IMRT was SABR. And these are the dose volume histograms that show the improvements over the years on the bottom. And it's just quite striking. And it shows it a little bigger. And the spacer, again, is a gel that we put between the prostate and the rectum through the perineum between the scrotum and the anus, and pretty much eliminates rectal toxicity, pretty much eliminates it. And then, oops, sorry. I don't know. This is an example of a prostate treatment. I'll just show you this video quick. So this is an MR Linac treating a prostate. The prostate has been pushed way forward because of a big gas bubble in the rectum. And then they ask the patient to pass the gas. The machine detects that the prostate is back in its spot, and then you heard the beam turn back on. And this is all automated. Nobody did anything except wait for the machine to figure out that happened. The hot thing is adaptation. The MR Linacs are one way to do adaptation, and I don't know that they have any MR Linacs in Ukraine, but
No MR Linux
there's
yet.
a type of there's one called Ethos, which is a Linac. It's like a Halcyon turned into a adaptive machine, and you could have that soon. It's a really hot thing though, and what it basically says is let's change the field at maybe even a treatment to treatment basis. And the trouble with the whole strategy, in my opinion, it's basically going to change. If the tumor shrinks, it's going to treat a smaller tumor. If the tumor moves, it's going to realign the beams. But like this is a lung tumor on day 1. And so let's say we give it a conventional treatment, 45 gray and 15. Here's what it looks on day 12, which to me looks exactly the same. So nothing has changed on day 12. You're almost done with the treatment. If treatment finally finishes day 19. Day 100, it looks dramatically different. But during the treatment, didn't look changed at all. So if you really wanted to adapt, that is to shrink the field to treat the smaller tumor and not treat so much normal tissue, you should have waited to day 100. But nobody does that, right? I mean, we all, and so I really don't expect many changes with conventional radiation or even with conventional SABR. If, SABR might be Monday and Thursday or Monday, Wednesday, and Friday, you're not going to see any changes in the tumor in that interval such that you could adapt to it. So it's true of both conventional radiotherapy and conventional SABR. And then let's be honest about what really affects tumor response. We talked earlier about DNA damage and repair, which is the justification for dose escalation, but there are also stromal effects, a tumor microenvironment. The immune system helps you a lot. If you treat a patient who has an impaired immune system, you're going to need like double the dose of radiation because you are getting so much help from the immune system. And then radiation can really call different cells in and out of the microenvironment. We cause a lot of inflammation. We didn't think about any of these things except DNA damage and repair for all these years with radiotherapy. So let's do question 4. which of the following features are something that you react to in an adaptive treatment, should not be used for adaptive radiotherapy. And so I listed 4 of them: position of the tumor from treatment to treatment, changes in the shape of the tumor, changes in maybe a PET scan generated SUV before and after the treatment, patient reported tolerance of therapy, or none of the above. In other words, if you choose none of the above, then you can use all of those to adapt the treatment. Well, that's a terrible question. I'm sorry, I didn't phrase that very well.
I think it's okay. They're getting it. I think
Mhm.
it's fine.
Yeah, you can probably close the poll. It's kind of an easy one. Any of those could be used for adaptation. Now, the vendors of the equipment only plan on you using the first 2. That is, they're going to give you a very systematic way to reposition the treatment, and then you'll have a ability to generate a new plan for a changing either target shape or normal tissue position or shape. But those other things are actually more interesting to me. They're things that could very much personalize the treatment in ways that we have never personalized radiotherapy. And in general, split courses of SABR would facilitate adaptation. That is, if there was a long interval, intentionally long interval between treatments, like SABR is in the US is usually given Monday, Wednesday, and Friday, or some people give it daily, but like we give it twice a week. But longer than that, I'm talking longer than that. These changes could constitute real opportunities to adapt. For example, if you want the tumor to shrink, then wait for it to shrink. If you and that constitutes a delta. It was this big before, and now it's considerably smaller. That's mathematically a delta. And there could be biological effects, degrees of apoptosis, debris from the explosion of the treated cells, microenvironment changes, etc. And that's where pulsar comes in. And I can't help myself. If I talk to anybody about SABR, I have to talk about pulsar. Because I think that SABR is moving toward this pulsar. And the pulsar is a gimmick where we purposely put pauses between the treatments. So it uses a high dose of radiation, at least 6 to 8 gray, to halt tumor progression. So you gave a dose of radiation, fancy techniques like we just described, and now the tumor is reeling in grief, in misery, because you've just hit it hard with radiation. And the dose should be high enough to afford months of durable control. And 6 to 8 gray will do that, as we know from randomized trials. 8 gray in a single fraction has just as good local control as 30 gray and 10 at 3 months. Then you stop, like for weeks or months, and then reinterrogate to see what has changed. And because your adaptation is the response to change, and so you're hoping that the changes will not only be many but be big. And then you use that information to plan your next dose, and the next dose may be a different dose. The next SABR treatment might be a different dose based on whether it was a good response or a bad response. And then you keep going until you boom or bust. And then, so during the pause, of course, tumors will move and tumors will shrink, but biology will happen, including all sorts of metabolic changes, biologic changes. And it might be very reasonable to rebiopsy the tumor to see what kind of changes these are exactly, and that take time. And so these are the advantages of pulsar. Pulsar is blatantly less toxic. It allows for tissue healing between treatments. Remember I talked about clonogen migration? Wouldn't that be great to give it some time for those clonogens to migrate? And the cellular repair, which is the basis for daily radiotherapy, is 1 to 2 hours. And so in 1 to 2 hours, half of the tumor is going to repair or not. And so in 5 half-lives, which is 5 to 10 hours, all repair pretty much will be done. 99% of it will be done by that time. And that's why we treat tomorrow, because all the repair that's going to repair is repaired by 10 hours. Tissues, though, are very different. Tissues take much longer to heal than cells do. Tissues take, again, weeks and months to heal. So, the surgeons don't operate every day. They operate once and then let the patient heal up if they do a staged procedure. So pulsar is more like surgery then, trying to take advantage of that. I think I'm going to skip over this because I'm running out of time, but the spinal cord tolerance experiments. Now, second, the response to adaptation with pulsar. Am I running late? Yeah, I'm running late. Radiation target volume and the timing of pulses. So let's say you start out with a cartoon tumor that looks like that. You treat it with a 10 gray of radiation and it grows. That's very important information. It grew on a big dose of radiation, and so you might increase the dose for the next pulse a month later or add a sensitizer. Now it finally behaves itself, and you give them maybe 5 pulses and add a drug. Compare that to another tumor in a different patient where it shrunk. Again, very important information. You might decrease the next pulse dose and only give 4 treatments. And so that's all based on shape, but it could have been based on all sorts of biological parameters that may change from treatment to treatment, including the tumor microenvironment, and the host tolerance of it. And if you interrogate these things in a systematic way during the treatment, and I think the question is, should you continue what you're doing? Should you intensify it? Should you de-intensify it? And it's all very complicated, sort of begging for artificial intelligence. And these are routine things that we can look at to make these decisions, but there can also be biomarkers and repeat biopsies and things like that. And imaging is probably the future of this type of assessment, because imaging now can image biological processes, not just anatomical processes. Here's some examples of really hard cases. This is a renal cell cancer. Big tumor next to the airway and another tumor next to the trachea and the esophagus. This is a risky treatment because it's overlapping PTVs with the esophagus and trachea. It would potentially be a risky treatment if you did that. You have to give big doses per fraction with renal cell because two gray per fraction is a joke when you treat renal cell. But here's what happened. So the first pulse looked like this. The tumor shrunk dramatically for the second pulse. And treating this tumor in the bottom right is dramatically different than treating this tumor 3 times. And so this is why it's less toxic. We've got protocols now going on for pulsar in rectal cancer where they're escalating the dose with a 5 fraction treatment, giving the chemo in between the pulses, and then biopsying the tumor, sending it to the lab and looking for all these, very sophisticated methods. I think I'll skip that too. So question 5, and we're almost done. Which one of the following statements is true about pulsar? Accelerated repopulation could be the undoing of pulsar. B, profound biologic change takes considerable time, that is more than a day. C, cellular repair and organ tissue repair takes about the same amount of time. And D, once the tolerance is exceeded, normal tissues rarely repair. Okay, looks good. Looks good. Yeah, B is the right answer. And remember I started the whole lecture saying that the 4 R's of radiobiology, only one of them applies, which is reoxygenation. And the accelerated repopulation R of radiobiology doesn't apply to SABR, and pulsar is a subset of SABR. And the cellular repair is hour or two, organ and tissue repair is weeks and months. And so that's what's the basis of the questions. So in conclusion, SABR, SBRT, SRS was developed initially to carry out severe DNA damage in tumors. That was the motivations for it. That's why we gave higher and higher doses, both in the brain and in the body. And evidence showed that enabling technologies could avoid intolerable late effects, which was very encouraging. Currently in the US, over a third of the patients are currently treated with SABR. And SABR is evolving to adapt to biology, which is very exciting. And it can be a degrees of biology. It doesn't have to be some fancy sequencing for a personalized approach. And I'm sorry I went over.
Oh, No worries. That was excellent lecture. Thank you so much. It was great to see your pioneering spirit and the thought process, how you develop the technology. It's just incredible. And I also love your out of the box thinking, you know. You did it's just you think differently than other people. So that's quite incredible. A pioneer, a true pioneer. So we're really lucky to have your lecture today. I would like to open the floor for questions and discussions. In the meantime, you can also type your question in the chat, or you can turn on the microphone, ask the question. In the meantime, I'll ask you a visionary question. What do you think will happen in, let's say, 10 years from now with Sabre or Pulsar? How do you
Oh,
envision
I
this?
think that first of all, when I was trained, we were told to sort of compartmentalize radiotherapy. Don't let it get screwed up by drugs and stuff like that.
Mhm.
And I think that it'll take some collaboration, but I think that we will learn to integrate drugs with radiotherapy like we never have before. And like drugs are given in cycles. And one of the reasons I like Pulsar is that um, like a drug will be given every 3 months, and then they'll or 4 months, and then at some point the patient can decide whether they want to continue it or not based on the response. And I think that Pulsar will add right into that equation. That is that we might give a pulse of radiation followed by a checkpoint inhibitor. Hopefully you'll get a better immune response from it. But if it's poorly tolerated, the patient could say, I'm going to forego further pulses, and I think that'll be way more affordable. I think like in a war-torn country like
Mhm.
Ukraine is currently, and I'm so sad about that, but these are the type of treatments you should be giving. And I can't do it here. I have to do it on trial for most things. But I
Right.
mean, I think that, you know, it's dangerous literally to come to the radiotherapy treatment center. And so I think that you could use this strategy as a response to the war, and potentially get a benefit to people for their treated cancers and still not expose them to so many risks. And so we'll see. I hope I excited some of you at least about this type of an approach. And in the US,
Mhm.
whenever you introduce something new, everybody hates it. It's almost a clue to whether it's a good idea or not. It's how many people don't like it.
So did you get a lot of hate for Saber in the beginning?
Oh, 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 I mean, I couldn't, that first paper I showed you with the dose
Yeah,
response,
yeah. Uh-huh.
I sent it to four journals before a kind of a
Mm,
low-level journal would publish it.
mm,
And
goodness.
it was funded by an NIH grant. It was a formal protocol funded
Mm,
by, and it couldn't get published in even the radiotherapy journals. And so, uh, anyway, again, I don't mean to make people uncomfortable, but like during COVID, SBRT really took off because
right, right.
people didn't want to come to the hospital. And I think
Absolutely.
Pulsar is really a another opportunity for us to both make healthcare more affordable,
Hmm.
integrate it better with systemic therapy. There will no longer be a period moving forward where people don't get drugs. People are, the drug approach, which has been so scientific and so biology oriented, especially with targeted therapies and immunotherapies, not so much chemo. People are going to get those treatments, and we've got to figure out how to integrate them with local therapies like radiotherapy. And giving 30 fractions of 2 gray is not the answer. That is
Hmm.
not the answer.
Yeah,
So
definitely. What would you suggest for Ukrainians starting their SBRT programs?
I would probably not go to the high doses that I just described in our early. First of all, I think that was a fundamental mistake. I don't think we needed to go to 50 gray in prostate cancer. And so I would do more modest doses, and the
Hmm.
modest doses work very well though. And so like a really common dose that we give is like 8 gray times 5. And I think you can feel reasonably comfortable with these more modest doses, and you don't have to do pulsar off the bat, but if it's a risky situation, I would, because pulsar is way less toxic than SABR in general. So if you were going to give 40 gray and 5 near the esophagus with SABR and do it every other day, the toxicity will be way greater than if you did it once a month. Dramatically.
I see Nadia Goncharenko has a question. Nadia?
Please.
Hello, Dr. Timmerman. Thank you for your lecture. It was really inspiring and a lot of new information. Also, I really interested in this pulsar treatment. You showed a huge tumor in lungs and near the esophagus. And my question is about tumor volume. What is the restriction for the volume of tumor that could be treated by these high doses? Maybe I thought that it should be small tumors only, but maybe some new protocols about it.
No, we in those original phase 1 studies for like primary lung cancer, we divided tumor size into 3 groups: small, medium, and large. And the large were 7 centimeters, so they were huge. And the large had poorer tolerance than the small. That that just from intuition. But the large ones still tolerated pretty potent dose, and we went up to 72 gray for the large tumors and had toxicity. So the best they tolerated was in the 66 range or something like that. I would not give that anymore, but that's what it was tolerated. And so I think you can treat very large tumors, but the larger the tumors, the more likely you should think about pulsar, because if you give a big dose of SABR every day or every other day or every third day and treat a very large tumor, your risk of toxicity is, of course, higher. And therefore, but if you have that big a tumor, you need treatment. And so it's not like you can just turn your back on the patient and tell them to go get drug therapy.
Would you fractionate more? For example, at Stanford, we do 8 fractions for these type of tumors, very large
I don't do that, but for me, 5 is fractionated.
Okay.
So 5 is pretty much the most I do, but I do 5 in a lot of people, and big tumors would be something I would do 5 in. I don't ever give 8, but that's the same spirit, the spirit of, and then use those treatment planning strategies. If you're next to some, like a big sarcoma next to the stomach, you got to use the IMRT to try to steer that fall off dose away from the stomach very aggressively, very aggressively. Whereas in other cases, like a lung met or liver met, you want it to be isotropic and have it fall off sharply and steeply in all directions. But like I just treated a 8 to 10 centimeter tumor in the liver in a patient the other day, and I'll give them 5 treatments. But in a small tumors, what I do for small tumors is I give them 1 treatment and get it over with and let them go on with their life.
Yeah, that's what we do.
Yeah, so I give them, if somebody has like I have a patient that has some small lung mets, then they'll get 1 treatment. It'll be a pretty high dose. It'll be at least 24 gray. But, that's very similar to the brain, right? Because in the brain, we give, 15, 18, 24 gray in single fractions to brain mets.
That's right.
Thank you.
Any more questions? Oh, Serhii?
I'm sorry if I'm not sure if I can be heard quite.
Yeah, we can hear you.
Thank you very much for a very interesting lecture. I was wondering that at the beginning you mentioned that this immune effect would happen, I think, 15 gray or more. So that led me to thinking that if there are some doses in between that are kind of less useful, yes. And but on the other hand, that most of the protocols are in the size of the fractions is gray, 8 gray, 10 gray, for example.
Yeah.
So how would you align that? That is kind of a part of the question. And also, if you speaking about heterogeneity of the dose distribution, so how much of the volume is enough to cause this immune effect? Maybe if there is just a spike of the dose in the middle of the tumor, that would be approximately to the dose of 15 gray, let's say 150% in the middle of the tumor. Would that be causing this important effect?
See, this is the coolest thing is we're talking about these biological things. And, 20 years ago, all radiotherapy people did was talk about technologies. And
Yeah.
I'm just so thrilled with the nature of the question and the way you're thinking about this. And, so I showed you in vivo, but in a laboratory model, mice, what those doctors found in terms of immune stimulation. And they said 15 gray. But the point is it's not 2 gray. And so I think 8 gray is a immune stimulatory dose. I very much think that. And we give that a commonly for the purpose of immune stimulation. And so it wasn't settled at 15 gray because of one mouse experiment. And in terms of giving a part of the tumor a treatment for this effect and maybe give another part of the tumor this dose for this effect, this is brilliant. And now it'll be hard to sort out. You're going to have to do a lot of work to figure out the answer, and you're not going to get the answer from me because I don't know. But these are the kinds of questions that people in our field have to ask because we've never asked them. We were always the techno people, right? And yet we are holding a therapy. This SABR therapy is so powerful, and its potential is barely realized. Barely. I mean, we could help people dramatically more than we currently do if we could only figure out the very questions that Sergey was asking.
Great question, Sergey. Yeah, excellent.
It's so exciting to hear that people are thinking about these kinds of things because it's absolutely true. In the past, we just gave homogeneous dose to a huge field and hoped the patient did well, and most of the time they didn't.
Yeah. That's right. But there is so much of the radiobiology that we don't know and don't understand, right? I think we are quite behind on that, and it's
but it's opportunity as well.
Opportunities for us to learn. Yeah.
In the U.S., I don't know about Ukraine, but in the U.S., the young people thought the field of radiotherapy was dying. So 5 years ago, nobody wanted to go into this field. Well, how did we ever get to the point where young people had no excitement about your whole field in medicine? And now that's changing. I think but things like SABR changed it.
Yes.
If all we had was conventional fractionation for another 100 years,
it'll be boring.
So we are with a therapy that has huge potential if only we try to exploit it. And it'll be a lot of work.
I will ask a little bit more mundane and practical question for Ukrainians on behalf of them. So a lot of them, as you mentioned, as you saw on my slide, complain about absence of 60 couch. So you explain nicely that it's not totally necessarily necessary, right?
Yeah.
But what about motion management techniques? So what would you say about that? So if the clinic does not have any motion management technique, what would you recommend?
So when I started doing SBRT, we didn't call it SBRT. I called it extracranial stereotactic radioablation. But this is in the mid 90s. I didn't have 3D. We did the plans in 2D. I didn't have a multi-leaf collimator. I didn't have image guidance, and we treated lung cancers that were obstructed in the bronchus. We used a bronchoscope to sort of see where we wanted to treat relative to the airway, and so I guess you could call that a fiducial, but it was all viewed in 2D. And we gave them good treatments. I don't want to do that again. In other words, I love my technology. I'm a sort of a spoiled technology person, but you don't need all that stuff to do a treatment, especially if you don't go to the super high doses. I think that for motion, I would be careful the diaphragm is a surrogate, because the diaphragm may move way more than the tumor does. But if you could get slow CAT scans, like if you're able to change the speed of your CAT scan acquisition, you could create sort of a MIP-ish looking thing, you know, where the tumor has some likelihood of being go up here and down here, and you capture that with artifact during the treatment, during the scan. Or do multiple scans,
Right.
you know, where you could merge them. That's a lot of work, but that's possible too. So there's all sorts of ways to deal with it. Abdominal compression was used early on because it was cheap.
Yes. And
And
I think it's one of the cheapest options for
yeah,
motion management.
and we still use it. I just simulated a patient this morning with abdominal compression. And so it's not like just because it's simple and you don't plug it in, that doesn't mean it's not useful. So I think that all of those are possible.
Okay, so that's very encouraging, but also you showed some scary pictures, right, of necrosis. So maybe word of caution for
Yeah,
organs at
I mean, I
risk.
think the biggest, you know, our urge when I was trained, and I'm sure you were trained the same way, when in doubt, expand the field. That's how I was trained, and it was in an era of 2 gray. 2 gray is a kind and gentle fractionation, and so it's reasonable to extend it a little bit because it's not going to change the toxicity very much when there's uncertainty. That is the biggest reason when somebody is transitioning from 2 gray to, you know, 10 gray or 20 gray, they do that, make a field too big because they're not quite sure where the tumor starts and stops. And that's what leads to the toxicity. You know, and so my point is, do something else to not expand the field, to get more confidence another way. Maybe show the films to a colleague, or get a better film or something to try. In other words, we want to treat as small a target as possible. When in doubt, do not expand the field.
Okay, that's a
This has
good
been in most
mantra.
cases where I've seen bad outcomes, and I was given a chance to review somebody else's work. That's what they did. They made the fields too big and included way too much normal tissue in the ablative zone. It's ablation. It's going to
Yes.
wreck it.
How high do you go for hotspots for lawn sabers, for example?
It's common for us to prescribe to like the 70% line. The Gamma knife, we go all the way down to the 50.
Right.
But in the body, it's you know, we don't have flattening filters anymore, so we have flattening filter free mode.
Right.
But we don't usually go down as low as 50. We typically are in the 70% range. So
Yeah,
it could be a
the same with
30%
us.
30% hotspot somewhere in the target. Yeah, and
Sounds
that hotspot better be in the target. Let me make that
Oh,
clear.
yes, and GTV, absolutely. Okay, so I see the question in the chat. In your opinion, what are the limitations of using respiratory control system for lawn saber?
What do you mean by respiratory control systems? Does that mean like so what we do is we assess the motion. We call it motion assessment. And sometimes I'll use a mini 4D scan, they call it, where you just scan right through the tumor and watch it move. Or in the old days, I did fluoro, believe it or not. I would just watch the tumor move on fluoro.
That's good.
And I'd put a ruler on the patient's chest with some little lead markers. And so that's motion assessment. And then I would say to myself, if it's moving too much, I got to do something about it. And the do something about it is called motion control. So if that's what you mean by respiratory control systems, I call it motion control. And I use 3 methods. I use no, 4 methods. I've got a breath hold technique that we use, where we sort of monitor the tidal volume and put them at a certain tidal volume, have them hold their breath. That one's really hard. I'm not sure that's a good one to use first, but that's quite feasible. Abdominal compression is forcing a patient to, not forcing, it's encouraging a patient to breathe with their chest wall. So as I stand here and I breathe, you don't see my chest moving. But if I want to, I can breathe with my chest. Watch me.
Yeah.
Now, the beauty of that is that you notice my right chest went up and my left chest went up at the same time.
Yeah.
The force is pulling tumors like this. Equal and opposite forces cancel motion, whereas diaphragm breathing is like this. And so every time this goes down, the tumor's force just goes down. Every time this goes up, the tumor's force just goes up. No equal and opposite forces canceling tumor motion. And so the chest wall motion is way preferable for a tumor that moves with respiration. And so we just use a compression to encourage people to breathe like I just showed you. I don't need compression. I know how to breathe like that on my own. Have you ever seen a runner at the end of the race when they put their elbows up on their side and they breathe?
Yeah.
They're trying to lift their chest wall to get a bigger tidal volume. That's
Oh,
chest wall breathing.
okay.
So that's number two. Number three is tracking. So our CyberKnife tracks fiducials and stuff like that, and they create a motion model and then try to predict where the tumor is going to be next. And then four is the gating. And I haven't used gating much in the previous era, but I'm using it now on the MR Linux because that's how they like that prostate thing I showed you. That's a gating. Does that answer the question?
And what are the limitations you think? So currently we are using some surrogates for breathing motion, right? We don't actually track the exact tumor necessarily. Maybe reflection does it better because it tracks the
But if you,
signal.
yeah. Well, let me just say in general, if you're treating a
Yeah,
tumor in the upper chest, tumors in the upper chest don't move very much. So you
right.
skip it. If the closer you are to the diaphragm, the more likely you're going to have a breathing problem. The lung is a compressible organ. So if you can't do anything with the lung, you'll probably get by because it stretches and compresses. The liver is a big problem because the liver is a non-compressible, for the most part, organ. And so any motion that happens to the diaphragm will also happen to the liver.
Mm-hmm.
And so, boy, it'd really be nice if you could do something for motion in the liver, because otherwise you'll treat a really big volume or you'll miss. What else could I say?
Yeah, that's pretty good. I wanted to translate one of the comment from Dr. Boyko here. So she said that she's been working in radiation oncology for over 20 years and 8 of them on linear accelerator. And today she received a powerful pulsar of positive emotions, new knowledge and ideas. And it felt like taking a fresh breath of air. And thank you so much. So that was incredibly interesting, exciting lecture. So it's such a nice review. You see, you're making Ukrainians pulsing. So amazing. Sirhi, you want to add something?
Did you say me or?
Just
Yeah,
sorry.
Sirhi. Yeah.
thank you very much for the lecture. I didn't have any comments. Wanted to say gratitude to Professor Timmerman.
Yeah.
Thank you very much.
Thank you so much. We're so grateful. If people want to turn on cameras, we'll take a photo with Dr. Timmerman. So it's not too late where you are. You want to turn on. Oh, and Victor is here with us. So excellent, Victor.
Oh, hey, Victor.
Yeah, that's
Just an
awesome.
opportunity. We just beamed on, so I have a minute to turn on the camera.
Yes,
Dr.
let's
T.
take a photo with Dr. Timmerman. So wait 1 minute, maybe. Anyone else turn on photos? Turn on cameras? Okay, are you? Oh, okay, more people joining in. Do you see all these happy Ukrainian faces? Okay. Oh, Serhi. Okay, great. So I'm taking a photo. Smile, everyone. Okay, great. Excellent. Thank you so, so much, Dr. Timmerman. That was incredibly inspiring. We are all pulsating with new energy. Okay, everyone. I see you next Tuesday for next lecture. Bye-bye. Have a good night.
Thank you. Bye.